Okay. Hi everyone. And this is a talk on metabolic syndrome erectile dysfunction. Don't look at it. So, what's the definition of erectile dysfunction? Harrison tells us that it's an inability to attain and or to maintain an erection of sufficient rigidity and duration so as to get a satisfactory sexual intercourse. This teaches if a person is not able to attain an erection, that is ED. If a person is able to attain an erection but not able to maintain the erection, that is also ED. A person is able to attain an erection, maintain the erection, but not the sufficient rigidity that his partner wants for a sexual intercourse, that is also erectile dysfunction. A person is able to attain an erection, maintain an erection, that too of the sufficient rigidity, but his partner doesn't get a satisfaction out of the sexual act, then also the purpose of erection is failed. That is known as ED or SD. When we all used to study for MBBS MD, ED was called as nothing but impotency. Open Harrison till 16th edition, second volume, second chapter used to be always on impotent men or impotency. Now by the NH revised guidelines 1992, the term impotency itself is deleted from all the textbooks, because addressing a male as an impotent guy, this guy is an impotency or transgender, whatever, is thought to be a great insult to manhood, because men can have decreased libido, and the most common sexual problem in men less than 45 years is not ED, it is actually premature ejaculation. Age more than 45 years, the predominant problem is erectile dysfunction. So basically ED is no longer impotency, so and ED is no longer erectile dysfunction, it is endothelial dysfunction. And what's the biggest risk factor? Such as just male aging study. That's why I told you I've taken everything from Harrison, just stitch and finish. Only 10% of men less than 45 years have organic ED. That is age 30, 40 years. Someone comes and tells in the OPD of an endo and uro that I'm having ED. 1 in 10 only have organic, remaining 9 out of 10 are having psychogenic ED. Age more than 60 years, 50% of the people may have some sort of organic ED. Age more than 80 years, 80% may have some sort of organic ED. That never means that a guy of the age 80 or 85 years is not able to have a sexual intercourse with the partner. He may be having tumescence sufficient enough to have an intercourse with the partner, but he may not be enjoying that rigidity of the penis that he used to enjoy before the age of 45 years. So, what are the stages of male sexual function? First is the stage of libido. You are seeing a lady or a guy in a whatever homosexual getting the kick of sex, you are having libido. Second is the stage of erection, where the blood pumps into the corpora and penis get into a stage of erection. So, basically, first you are thinking that you want to have a sex with a lady, and now two types of erection is there. Always understand. First type of erection is known as a neurogenic erection, your thought causing an erection. When you are in your teens, till the age of 20, 30, 45 years, the moment you see a female you want to have sex with, moment you chat with a female you want to have sex with, moment you hear the sound. In our childhood days, the only movie or whatever magazine, Filmfare or Debonair, you see the photo of a female that you want to have sex with, you have a tight erection of your penis without even touching your penis. That is thought causing an erection. That is known as a neurogenic erection. As your age increases above 40, 45, 50, even the strongest desire to have sex with a lady, the strongest desire, even hearing the sound, hearing the whatever, seeing a picture or even touching will not produce a full erection of the penis. You have to touch and caress your penis to have an erection. So thought causing an erection is a neurogenic erection. Touch causing an erection is known as a reflexogenic erection. So how does touch cause an erection? We know, we have studied in MBBS, the peripheral nerve supply of the perineum area is the pudendal nerve, S234. So you touch the pudendal nerve area, so the local reflex that it goes to the S234, from there to the parasympathetic nerve fibers causing an erection. That shows that the moment you are till the age of 30 or 45 years, your penile endothelium, erectile dysfunction is no longer known as impotency, and ED is no longer erectile dysfunction, it is just endothelial dysfunction. A person having adequate libido in the absence of stress with normal testosterone. A guy comes at the age of 30 years, is having full libido, desire to have sex with a lady, no stress at all. They are girlfriend, boyfriend for years, no stress at all. You are checking his testosterone. Testosterone is 10 nanogram per ml. A person after having adequate libido in the absence of stress with normal testosterone is not able to produce an adequate penile erection. That shows that his corporal cavernosal endothelium is not able to produce nitric oxide for penile vasodilatation. So think whatever I have told. ED is no longer erectile dysfunction, it's endothelial dysfunction. When we used to study for MBBS, we know penis is made up of two groups of vascular smooth muscles, a central midline corpora spongiosa and a pair of corpora cavernosa on either side. Don't look at this, because penis is made up of just smooth muscles. This is the cross section of a corpora cavernosa. When your libido, what is occurring? Your impulses come, neurogenic erection, impulses come from the brain to the spinal cord, to the S234 segments, to the parasympathetic nerve fibers, and ultimately this is the endothelium. Endothelium endothelium produces nitric oxide. Nitric oxide is the most potent vasodilator in the body. So when you're thinking of a lady, your age is 15, 20 years. So one big businessman whom I saw day before yesterday from Dubai, because nowadays 18 days I walked there, 12 days only in Kerala. So he was coming and telling me, doctor, I am having diabetes for 15 years. I tried all tadalafil. I am taking 40 milligram. Nothing is working. I am taking intracavernosal, alprostadil, pepaverin, phendolamine. He buys everything from Sudan and comes and mix it in an insulin syringe and takes everything. Still my erection is poor. I want to go for a penile process, but two of my friends went for a penile process and they had a failure. So he's fearing once you go for a penile process and the failure, you have no looking back, your penis is totally out. So he was telling that, doctor, when I was in my childhood, 8th standard, 10th standard, the moment I see the advertisement of Crowning Glory, where Dimple Kabadi was moving left, right, he had a tight direction of your penis without causing anything. Now, whatever he thinks or whatever libido the penis is not at all moving, that is ED. Why it is not at all moving? Because ED is no longer erectile dysfunction, it's endothelial dysfunction. His HbA1c is 8.5, his BP is 140/90, his LDL is 132. All the Kerala Ayurveda doctors is taking LDL and smokes 3 packs of Rothmans and all the cigarettes per day, and belly is 120 centimeter. Then he can just dream of erection at the age of 5th or 10th standard, because the biggest risk factor of ED is no longer diabetes, it's abdominal obesity and metabolic syndrome. So previously during MBBS MD we had an MCQ question, what's the biggest risk factor of erectile dysfunction? Doctors used to answer diabetes, diabetes, diabetes. Now HbA1c never kills your penile endothelium. Studies in type 1 diabetic children have shown that you are having children with type 1 at the age of 15, 17 years, they are having poor glycemic control. You follow up them till 60, 70 years, 80% have a good penile erection, because HbA1c is alone the culprit in type 1 diabetes. They are not having metabolic syndrome per se. Whereas 35% of the guys coming with type 2 diabetes, the presenting symptom itself is an erectile dysfunction. So the biggest risk factor for ED is no longer diabetes, it is metabolic syndrome or abdominal obesity. That is why Rubin Shah from Bombay, who is considered as the father of Indian andrology, because he devised the Shah metallic process in Hinduja or Jaslok, everything. He was asked the question in 1 year back, and in Indian Institute of Science, there was a hands-on conference for penile process by the urologist. I was just taking on testosterone. He was asked the question, doctor, what is the mantra for immortal sex? Suppose a guy wants to have an immortal sex at the age of 70, 80, 90, what is the mantra? He was telling that never smoke, exercise properly, keep your abdominal girth less than 90 centimeter. If at all your cholesterol is high, take a statin, because the biggest risk factor for that's endothelial dysfunction is the same as the biggest risk factor for heart attack. That is your LDL. Second is your abdominal obesity. Third is your smoking. That's why recently there was a study published in JAMA where 45 to 55-year-old people with moderate ED were taking tadalafil 5 to 10 milligrams. So not sildenafil, tadalafil 5 to 10 milligrams. Were divided into two groups. 50% were asked to exercise properly and quit smoking and take a statin, and remaining 50% was to continue to take tadalafil in whatever dose. After 6 months of exercise and statin, 80% of the people who were taking tadalafil 5 to 10 had a good erection without even taking any tadalafil tablets. That shows that ultimately it is your metabolic syndrome which kills your penis. It is not your insulin or it's not your glycemic control that's to save your penis. That's why the lead order in JAMA was asked a question, sir, what will you assess or what will you advise your middle-aged patients who have erectile dysfunction in the initial stage? He was asked the question, properly, never smoke, and always take a statin. Whenever possible, LDL is more than 70, take a statin. Statins and LDL. LDL ultimately kills the penis. Some guys come and ask, doctor, will LDL reduction in statin because a counter effect? Because statins always affect testosterone. We know cholesterol, pregnenolone, progesterone, 17-hydroxyprogesterone, androsterone, and testosterone. That's a pathway of testosterone. But you take statin also, testosterone level comes down by 1% only, where your abdominal obesity or insulin resistance itself can reduce testosterone by more than 30%. So just understand the concept. ED is no longer erectile dysfunction, it is endothelial dysfunction. The biggest risk factor for ED is abdominal obesity or metabolic syndrome. Just like Rubin Shah was telling, never smoke, keep your abdominal less than 90 centimeter. And how does abdominal obesity lead to ED? Because when we used to study for MBBS, it was the thyroid gland, which was considered to be the largest endocrine gland in the body. Now we notice the adipose tissue, which is a waste energy depot, that is now considered to be the largest endocrine gland in the body. As your adipose tissue gets more and more bulkier, your insulin resistance type, human necrosis factor alpha, interleukin 6 and resistance increases. This kills the penile endothelium. So that's why abdominal obesity. Now I have 3 more minutes, or give me 5 minutes. It will be good for you only. So ultimately, so this is the basic mantra, because the concept without knowing nothing, because my time was 15 minutes. Anything is okay for me. So understand this, the basic concept. Each gram of HbA1c more than 6 points. This is the famous slide which is present in all the diabetic conference by all the famous doctors. So each gram of HbA1c above 6.5, each millimeter of mercury above 130 by 80, each milligram of LDL cholesterol above 70, each puff of cigarette you smoke first occludes the narrowest artery in the body, penile artery, which is the diameter of 2 millimeter. Your coronary has a diameter of 3 to 4, your carotid has a diameter of 5 to 7, and your femoral artery has a diameter of 7 to 8 millimeter. Whereas your penile artery is the smallest artery where you can't put a stent, whereas you can put a stent in your coronary, carotid, and femoral artery. There you can take treatment only to prevent an endofunction. Just I was again telling, suppose you are building, and suppose whatever I require 3 minutes. So basically understand. So suppose you are having a whatever. This is the most important thing, because man can conquer oceans and man can conquer whatever continents, but ultimately you have a wife or any female who demands sex and you are not able to deliver that, you are finished. That's the same fate with Napoleon. Napoleon conquered whole world. We saw the movie, whole world, but ultimately Napoleon's wife was going with multiple corpors, and Napoleon every time was coming from Egypt, Austria, Vienna, everywhere back to France just to look out whether Josephine with someone else, or he used to come for surprise checking. That 2 hours of travel in horseback from Russia and to check Josephine, because ultimately when Napoleon died, many people thought that Napoleon had a minuscule testis and a gynecomastia. That's a Reader's Digest, and all the articles say that no one has seen Napoleon or Tipu Sultan wearing the whatever chest in an open field. So many people think that Napoleon was a Klinefelter. Actually, Napoleon had one hair only. Napoleon Bonaparte too, he died at 10 years because of measles something that time. But many other people think that he may not be a Klinefelter mosaic, because Klinefelter people are more voracious. They want to conquer other things because they are sexually always infantile. That performance is poor. Some people think that maybe in St. Helena he was poisoned with arsenic, and arsenic would have caused a gynecomastia and testicle failure. So whatever be it, understand prevention of ED is the most important thing, and men always miss the hormone. That is why what is the routine checking in a guy with an erectile dysfunction. Suppose you and me above 40 years are having some sort of penile dysfunction. You are thinking that the rigidity is not that good as before, or the penile rigidity you are not able to sustain for more than 15 minutes, or your ejaculation is getting much more faster. What are the routine tests? FSH, LH, testoprolactin, T3, T4, TSH, lipid profile, LFT, RFT, HbA1c, PSA age more than 40. Among the most important is testosterone. Understand which sentence I am telling. Because females have a wonderful thing that is known as a menstrual cycle. Suppose my wife is 42 years, she misses her menses for 3 months. What should she do? She will go to a gyne will do a UPT or an ultrasound for a PCOD, or an FSH prolactin TSH for a premature menopause, hyperprolactinemia or a hypothyroidism. Suppose a 45-year-old guy is not able to have an adequate erection with his partner, or not able to sustain, what will he do? First, he will not do anything. He will not go to any doctor. He will attribute to the stress he is having, smoking, alcohol, sugar, BP, cholesterol, BP, cholesterol, uterus of the wife that is being removed, or children who are studying in MBBS, or tell the glorious during my 35 years I enjoyed that, 40 years during my MD I went to Pattaya, I went to Vietnam. What is there? Your time to enjoy is when you have money, when your children are grown up, and you have enough money, that's the time to enjoy. So that is why your time to enjoy is 55, 60, 70. There is no age for sexual barrier, because ultimately sex should be safe sex. But people want to enjoy. Bill Clinton had a relation with Monica Lewinsky when Bill Clinton was 66 years, because he had a good thing. So ultimately it was working. So many times, many very VIP politicians sometimes come to me in Kerala and tell, his wife tells, previously he was a big problematic guy. Now he's very gentleman. He's a family man, totally looks after the family. So I know that what family, now he is not having, now nothing is working for him. Sugar, BP, cholesterol, I know. He comes and tells me personally, nothing is on ex-minister, ex-deputy GM, whatever. Nothing is working, sugar for 20 years. So he's gentleman with children, grandchildren like that. Otherwise, whatever people cannot walk in front of him. So that is why sex always you have to continue, and testosterone replacement. That's why whenever a guy thinks that his sexual performance is coming down, always check the testosterone, and testosterone replacement can be safely given in men till the age of 65 years. But before doing that, always go to an endo, just do a total testosterone and PSA, PCV. If PSA, PCV is under control, give testosterone. And this is the 3-line therapy. Suppose a guy at the age of 45 years, just understand the point, 15 years of diabetes, just like a doctor nephrologist I saw 2 days back, 15 years of diabetes, 45 years with abdominal obesity, already underwent angioplasty, comes with an ED. His testosterone is normal, thyroid is normal, LDL is keeping less than 55, no NASH, HbA1c 6.2, PSA normal, still the penis is not working. Then the first option is giving him a sildenafil, tadalafil, vadinafil. He's already taking a Viagra 100 milligram for more than 6 months. First 3 months it's worked, now it is not at all working. So he's telling telling that Viagra is not good, doctor. I went to Dubai, bought Cialis, Tadalafil from another brand. That is also not going to work because Cialis hardly works in a patient where sildenafil doesn't work. If you have PDE5 inhibitor, sildenafil, tadalafil, vardenafil doesn't work, then the second option is an intracavernosal injection. That's what's telling alprostadil. Look at the last thing and then finish. This is the thing that every doctor or you and me should know. This is known as a penile processes. This shows that there is never ending for sex because first line therapy fails. Many people are hesitant to go for injection, second line therapy. But second line therapy, it's not a priority. Every time you go to your partner, you can take an intracavernosal injection, go with a pain priapism. That's not a possible option. It's an option for a person who wants an intercourse once in 2 months or 3 months. A wife demands sex every other day. You can't go for a penile injection. For them, best option is nothing but a penile process. Two types of process: inflatable processes, non-inflatable process. It is just like a silicone breast in a lady. Inflatable is you are putting a bladder that is into your two corpora cavernosa. A fluid-filled sac is there. There's a switch on and switch off button. You switch it on, the fluid goes in. You have an erection. You switch it off, the fluid goes off, and your penis comes in the flaccid state. How do you think that?
We are running short of time.
So this is the last option. Yeah, it's the last slide.
Yes.
First I told you PDE5 inhibitor. Second is intracavernosal alprostadil. Third is always this is the penile process. From this is the last thing. Why did I tell about sex? It is an endocrinology for me. It's just like testosterone. It is my area is testosterone metabolic syndrome, making you aware that erectile dysfunction is no longer impotency. Erectile dysfunction is erectile dysfunction. Prevention of ED is important. But once ED occurs, don't think that testosterone is the sole treatment. Testosterone is low treatment. If testosterone is not low, if your TMD is normal, go for a PDE5. That is not working, go for an intracavernosal. If that is not working, go for a penile process. If you don't want sex, leave it. If you want sex, you have options till the age of 70, 80 or 90. That's the thing of sexual dysfunction and metabolic syndrome. Thank you.